I am doing my live Q&A. If you've got any questions, ask me. If you haven't got any questions, think of a question and ask me next week. But for this week, it's here and it's now. So it is time to go through what I have. And I'm just copying and pasting something because there was quite a long question at the end, which I need to read. Jackie's here, straight in at number 1. Jess is here. Right. So let's just go ahead and ask the question that I've got on my list. But don't let me. Khan's here. Hi, Khan. Good to see you. Hey, Jess. Good evening. Nice to see you. Ria Mill is here. Paste options. Wave. Don't really understand what the wave function is on Instagram, to be honest with you. Cheryl's here. Nice to see you, Cheryl. So, got some interesting questions here today. So I'm going to kick off with this one, if that's okay. This one says, have I got option to have local anaesthetic instead of general anaesthesia? We see the word of there. Yes. Well, I mean, it will depend, assuming the operation can be done under local anaesthetic. So that's, I guess, I guess that that's the first thing to say. So if the operation cannot be done under local anaesthetic, then you will have to have a general anaesthetic. So that would be a given. But if the operation can potentially be done under a local anaesthetic, then you could have the option to have it under general anaesthetic. So it could potentially sort of go both ways. I mean, we would normally advise you to have the least sort of anaesthetic possible. So if it can be done under local anaesthetic, we would normally advise you to have a local anaesthetic, because everything else being equal, a local anaesthetic is better in many ways than a general anaesthetic. And it would only be someone who would really, really maybe didn't want to have local anaesthetic that would have a general anaesthetic. It's always an option to have things done under a general anaesthetic. And occasionally we see people who are really, really worried about having something done under a local anaesthetic, like a mole or something. I had one not that long ago, and she was really, really nervous about it and wanted it to have under general anaesthetic, and that's fine. I mean, we have got the option for that because we do a lot of things under general anaesthetic. But I would say, it's better on many levels. It's just quite a palaver having it under general anaesthetic. Not only that, you have to be admitted into the hospital. It becomes a big deal. You can often go home same day if it's a short anaesthetic, but it just adds cost to it because of all those implications. So, so you have always got the option to have a general. Actually, this question, now I've reread the question, it's going the other way, isn't it? Have I got the option to have local anaesthetic instead of general anaesthetic? So if it can be done local, yes. I mean, if it's a general anaesthetic case, then you can't just have it done at local. Maybe this is talking about local with sedation, twilight sort of anaesthetic, which is a little bit different to local anaesthetic. So local anaesthetic is like when you're at the dentist, you're completely awake, injection in the area needs to be anaesthetized, and you are, completely compos mentis and awake. You walk in, you walk out. Local anesthetic and sedation is a little bit different. So local anesthetic and sedation bridges the gap between local anesthetic and general anesthetic, and you can do a lot more with local anesthetic and sedation than you can with pure local anesthetic. So this might be where that question's going. So so there are cases which are sort of standard, if you like, or the set way of doing it is with with general anesthetic. But you could, if you were worried or didn't want a general anesthetic for whatever reason, you could consider local with sedation. The classic example being, well, most breast surgery really, but I was going to say breast augmentation, but you can do pretty much most breast surgery under local with sedation. You can do body contouring, you can do tummy tucks, you can do gynecomastia. You can do things, but it and certainly patients can opt for that for sure. But you know, we'd have a discussion about pros and cons of both, because the fact of the matter is, anytime both ways are being done doesn't mean one's better than the other, and there are pros and cons of each of them, and it would be getting what would suit you. So yeah, we definitely have a conversation about what would be best for you and what would suit you, and if it is possible to do it under either local anaesthesia or general anaesthetic, we can have a discussion around that. Although often certain operations have a sort of standard way of doing it, like moles, standard way of doing it is for oh god, these things are fluffing up now. Standard ways for doing it is for local anaesthetic. Tummy tuck, standard way of doing it is general anaesthetic, but there are situations where you can have a discussion. Elaine, something I want to talk to you tomorrow about, hoping this is something that might be available for me. Yes, Elaine, it's available to all, Elaine. It depends on the op. For me, so yeah, if it's a breasty thing, local anaesthesia is an option. Although I would say there's one hospital that I work at in Solihull, the Parkway. They don't allow us to do local anaesthesia for whatever reason. Never quite got to the bottom of why not, but they don't allow local anaesthesia. You have, if you want local anaesthesia, you can't have it there. But the other hospitals can do local anaesthesia if that's what you would like. But definitely, Corinne, what is the difference between twilight sedation and general anaesthetic? That's a big question, Corinne, and the more I've looked into it, and really it's the lockdown, it's the coronavirus and all that, which has really pushed forward the twilight, because there was a time when the hospitals weren't allowing us to do any work there, and there were some places where we could only do local anaesthesia as twilight. Now we're back into the hospitals, and you talk to the anaesthetists and say, look, should we do some local anaesthesia with twilight? Now, talking to the anaesthetists, there are anaesthetists who would say there's not a huge amount of difference between local anaesthesia with local anaesthesia in general. Certainly for the things that we're talking about here, which is breast implants, breast reductions, and some of the bigger operations. So, you know, sedation can be a range basically for sedation, from something that'll make you a little bit drowsy just to sort of relax you, which would also be in the remit of local anaesthesia. But some of the things that I do under local anaesthesia, the sedation is quite deep, close to general anaesthetic sedation, really. So from a pure anaesthetic point of view, the anaesthetist would say there's not a huge difference between a GA and a local anaesthesia for some of these procedures. From a practical point of view, I do find that patients do tend to recover quicker with the local anaesthesia. So for a suitable patient, it is a good thing, and I do think it has worked really well for the times that I've done it, and I've been really happy with it. The patient has to be on board, because there can be a bit of wriggles and a bit of movement and things. It can be a bit of a challenge if you've got someone who you're doing in asymmetry, because if you're injecting a lot of local anaesthetic, it can make the size difference, can be a bit more difficult to see. So there are some surgical challenges with local anaesthesia, but and so basically, Corinne, I wouldn't like to say one's better than the other. As I say, there are some ops which I'd be more in favour for local moles. Some ops I'd be more in favour for general tummy tucks, and then there's some in between. Breast implants, particularly on top of the muscle and stuff. You know, using same size implants. Very happy to do that under local anaesthetic and sedation, and it's worked really well the times I've done it. But at the same time, general's still fine. You still go home the same day, and it's, you know. So practically speaking, from your point of view as a patient, the most common thing people say after a local anaesthetic and sedation case, when you say how did it go, is how did what go? What, you know, what was that sort of thing? So you are fairly sedated. You're not really compos mentis during the procedure. You're usually pretty sedated. So from your point of view, not a huge amount of difference. As I say, you might feel a bit of big jiggery pokery, and might feel a bit of pushing, pulling with the local anaesthesia, but then you might not remember it. Often people don't remember what went on there. So, I'll just stick with general. Have I not? Not that I'm trying to sell it, but yeah, I mean, yeah, I think, yeah. Right, what we got here is another question. The question goes a little bit like this. I wish to have this surgery, but of course I worry about complications. I've got to be honest, these are real, well, I say they're real questions. They're real questions they've given. I'm assuming someone's actually asked you. So there's a couple of weird ones today. I don't know if it's the same person asking all the questions, but anyway, that's the question as I receive it. I wish to have this surgery, but of course I worry about, I don't even know what surgery it is they're talking about. Yeah, I mean, I worry about the complications too. Yep, you're right to worry about the complications. I think any surgery will have complications, and my job is to tell you what's possible, and your job is to weigh up the pros and cons to see whether it would be a good thing to do. So, you know, it's I don't know how to answer that. It's not really a question, is it? It's more of a statement. I think probably the more junior, and maybe there was a time when I might be guilty of a little bit of, like, you know, when I show someone a photograph, patient might say, well, that scar's quite red. Oh God, goodness, a bit asymmetrical. One's a bit bigger than the other, or something like that. And I think there was a time when I would have said, yeah, but the scar's quite red, but it's early days. Oh yeah, they're a bit asymmetrical, one's a bit swollen. But now I just say, yeah, the scar's red. The scar is always a bit red. Hopefully it'll fade. Can't guarantee it. You know, there may be asymmetries. There may be problems. So there you can get infection, you can get swelling, you can get hematoma, you can get bruising. So, you know, there are potential for problems and there are potential for complications with any surgery. Anybody who doesn't get complications is not doing enough surgery, basically. Any surgeon, you know, best surgeon in the world is going to get complications, and it's just part of the job. So, and you know, we have to just share the risks associated with the implants, what the consequences of those risks are, what the chances of those risks are, and then leave it up to you to balance that up with the benefits you're going to get from the surgery. Because a lot of the surgery that we're doing is very subjective. You know, you don't have to have it done, but you may not be happy with something that you know could be improved with surgery. So having said all of that, it's very rare to get complications in cosmetic surgery. It's got a very low complication rate, fortunately. So I don't want to make you think there's complications going on all over the place, but you know, very low doesn't mean zero. So it does happen. So you have to know about the problems and you have to weigh up the pros versus the cons. Sarah Yates is in with a question. Is it possible to rectify a is that going to spell, is that spell checked something? Was that spell checked outie? Would outie spell check to none? None. What do you mean you got none belly button? Anyway, I'm going to answer the question either way. You know what, Sarah? The answer is yes. Now what's the question? Simple as that. Is it possible to make a belly button out of nothing? Yes. Is it possible to make an outie and innie? Yes. Oh, here we go. TT gone wrong. TT being tummy tuck viewers, for those who aren't familiar with the abbreviations. Now I have no BB now. So no belly button. Okay. So none. Yeah. Umbilicoplasty. Look at that. We've even got a word for it, Sarah. You can do an umbilicoplasty. You can recreate a belly button. Faux show. Yes, you can. It's a little bit like making a nipple, but in reverse. Obviously, a nipple's a bit that sticks out. A belly button's a bit that goes in. And the problem with making things like that stick out or go in is that scarring wants to find the path of least resistance between 2 points. So in terms of the nipple, it wants to be flat. In terms of a belly button, well, in terms of both of them, it wants to be flat. The closest, the shortest distance is going to be flat. So we're trying to sort of recreate a crater, if you like, what a belly button is. So, you know, the risk is flattening it off, to be fair. So the risk is that it can flatten off, but that doesn't mean it can't be done. It can definitely be done. You can definitely make a belly button from nothing. So if you have had a belly button that's died, or that's whatever reason your belly button's not there, a new belly button can be made. It's amazing, Sarah, what they can do these days. And you know, I wrote a paper on how you make the belly button when you do a tummy tuck, And when I'm writing the paper, you have to research all the research that's done in that area. And there's quite a lot of papers on techniques for umbilicoplasty, how you make a new belly button. It's one of those sort of little, there's lots of little things in plastic surgery, little nuances that plastic surgeons get very excited about and start planning all these funny flaps and ways and designs of how they make this and how you can recreate tissue. And it is actually more difficult than you think. I don't know if you think it would be easy, but it's not easy. It is more difficult than you think to recreate that hollow and get the shape right. But nevertheless, it's a possibility, Sarah. Not a common op, I would say to you, but certainly not unheard of. Sorry to hear you've had problems with your tummy tuck. The other thing I say to you, Sarah, is people who have problems. I see people who've had sort of problems and lots of issues and things like that. And I'm like, if you've had a lot of problems, the other thing I would think about, just at least entertain the thought of, is it time to sort of say, look, you know what, I haven't got a belly button, but I can live with it, sort of thing, because there's complications with any surgery. You've obviously had complications by the fact that you haven't got a belly button. So if you have another surgery, which is not a straightforward surgery that might not work properly, do you want to go down that road and keep on having potential for complications? Just going to throw that out there. Again, weigh up the pros and cons. Totally up to you, Sarah. But in answer to your question, yes, you can make a belly button. Can you please recommend the name of the best surgeon in your clinic? I believe they are all so good. So, thank you. You're welcome, Sarah. I mean, again, this is the question as I see it. I don't know if they've made it up in the clinic or someone's actually asked that question. So, yeah, I mean, do you know what? I keep on saying this, don't I, about the best thing, best implant, best surgeon, best. What I would say to you when choosing a surgeon is, even a surgeon within my clinic, because there's, we've got there's a few of us there that now work there. Just look for someone who you resonate with, who you seem to get on with. We've got Azam Faroa, who does mainly skin. So we've got some people who sort of niche into certain things. Azam Faroa does mainly skin. Kuram is a cleft surgeon, so he does a lot of facial stuff. He does the ears. But he also does the breast and body, like myself, and me, I just really do the breast and body. We're all fully trained plastic surgeons. That's one thing that I do make a point about. We're all fully trained plastic surgeons. So we're at the highest level of training of plastic surgery you can get to. There's nowhere higher. We're all consultants. We all are or have been consultants in the NHS, which is the benchmark. I'm no longer a consultant in the NHS. I left a few years ago, but both of the Kuram and Azam are both currently NHS consultants. So we're all, at that same level of independent practice, if you like. And if you want a skin lesion or skin problem, Azam's your man, particularly if it's skin cancer. Having said that, we can all treat skin, but that's Azam's specialty. But I do think it is important to find someone who you resonate with, who someone you get on with, someone who you think will look after you, because you can't guarantee you're not going to get a problem. You can research until you're blue in the face and have surgery with the best surgeon in the world and get a complication, or you can just rush into it and have some random surgeon who's maybe not qualified and got loads of complaints against him and have no complications. So you're obviously improving your chances by finding the good surgeon. Don't get me wrong, you are improving your chances, but you're not making it zero. You're not sort of you're not completely eradicating the risk. So you just have to get as much as you can and balance it as much as you can in terms of who you think will look after you. And what I always say to patients is that I can't guarantee you won't get a problem. But what I can guarantee you is if you get a problem, we'll look after you and we'll make it as good as we possibly can. That's what I can guarantee. I cannot guarantee you won't get a hematoma or an infection or a wound breakdown or a bad scar or whatever complication you might get, an asymmetry. So I can't guarantee those things won't happen, and I can't say that those things haven't happened to me, because they have happened to me in my life. I have had complications, I'm sorry to say. But if I get a complication, I will work through it with the patient to make sure I do everything I can to give you the best result possible. So that's the sort of ethos, and that's the ethos of the clinic, really. So that goes with all of us. So yeah, we haven't got a best surgeon, and there isn't a best surgeon. Just like there isn't a best implant, just like there isn't a best suture, just like there isn't a best technique for breast reduction, just like there isn't a best, you name it, car. Rolls Royce is pretty good, isn't it? Anyway, no, you know what I mean. You get my point. You get my point. Deborah Charlotte 007. Premiere tonight. Deborah Charlotte. Do you do fat transfer for breast orgs, please? Yes, I do, Deborah Charlotte 007. I do, Deborah Charlotte 007, but I don't push it, do I? I don't even know. Is there? I think there is something on the website. There is. There's a blog. I did a blog about it, but it's not huge on the website. And you might say, why is it not huge on the website? Because breast fat transfer for breast augmentation sounds like a cracking idea. Because you don't have to have any of the worries of implants, because goodness knows implants can cause problems. And don't get me wrong, I'll be the first to tell you the problems that implants can get. I do a lot of implants, but I always warn everybody about the problems you can get with implants. Well, short-term infections are the main one, you have to remove it, but long-term they can go hard, they can rupture, they can get a cancer associated with them. You know, you can get people describe illness associated with breast implants. There's all sorts of things with implants. So if there was a good way of doing something with your own natural body tissue, I'd be first in line. But I'm not first in line, Deborah Charlotte, because the problem with fat grafting is it's really subtle. And that's the thing that I try and make a point to everyone who inquires about fat grafting for breast augmentation. In my hands, it's really good for one side, for a bit of a subtle volume enhancement, for a bit of an asymmetry, particularly coronal irregularity, as long as it's not too badly scarred. So there are reasons why fat transfer works really well. But straightforward breast augmentation, it is really subtle. The volumes are small. So if you're looking at fat transfer, you're looking, in my hands, because you're doing both, presumably, usually for breast augmentation, you're with 50 to 100 mils. You know, more than that, you know, if you're going 100 to 150, that's a big one. So probably around 100 mils each breast would be a lot for a fat transfer breast augmentation. Breast implants, you can get a 200, 300, 400 cc implant off the shelf, boom, it's in, done. That's 400 cc there, done. So fat transfer is often quite subtle, and you often need to repeat it for that reason, because it's quite subtle and you might need to, so therefore it can be quite expensive, because you know, by definition, often people are very slim, so you have limiting the donor sites. I say by definition because people wanting breast implants are often quite slim. So it is not as popular as you would think it is. People are using it now with implants, this sort of hybrid augmentation where they put some fat over the top of it to cover it, a bit rippling and things, particularly if they're on top of the muscle. So it may be an adjunct with implants, but it does make it quite expensive, because fat transfer is quite a labour-intensive procedure, and therefore it's quite an expensive procedure, because it takes quite a long time in surgery, in theatre. Yeah. What implants do you use now? I had 2 breast aug already. Yeah. I mean, I don't particularly sort of, well, I normally use Polytech. Polytech is my sort of normal one for several reasons. But having said that, I use others. I use Nagel. I use Mentor. if you've got a strong view about an implant, if you've heard of one or you want a certain one, then you can have a certain one as long as the hospital can get them. Polytech are good because they cover the whole range. They're the only company that make an implant with every type of coating, except smooth. Use Nagel, it's smooth. But anyway, and they have got a good warranty. So, and I'm familiar with the range. So Polytech is the one I use. But if you had 2 breast augs already, yeah, maybe you're thinking maybe a bit of fat transfer you might be happy with, but you'd have to be comfortable with the subtle result. Okay, thanks. Is the fat taken from the inner thighs? Not usually inner thighs, Deborah, because the skin's quite thin on the inner thighs. So I tend not to say this from the skin at the inner thighs. Outer thighs, yes. Outer thighs, really nice donor site. Abdomen, nice donor site. So abdomen and outer thighs are probably the go-to ones. Kimberly's got infections. Sorry, wait a minute. Infections like I had. Yes, Kimberly, you had an infection, didn't you? Before, and you had to have, I think you had to have your implant removed, didn't you? So that was back before I think you're all right now, but last time with the other, you did have infections. Yes, so you know only too well, Kimberly. Infection is the thing that we worry about. I've got to be honest, as plastic surgeons using implants, it is a real issue and a real thing that we do worry about. Does the fat stay in the area? Yes, it does, Sarah. It does stay in the area, and it takes like a graft, just like a skin graft takes. So it's a permanent solution, and it will grow and it'll go bigger and smaller as you put on or lose weight. So it's a really lovely technique, fat grafting, an absolutely lovely technique. But it's about getting patients on board with the sort of result that can be achieved, because it is not the same as using an implant. An implant is much more predictable, much more volume can be added with an implant. I would be looking for a reorg with fat transfer in about a year. I'd say the smooth ones I've heard are better than the rough texture. Thanks for your advice. Well, again, Deborah, yeah, smooth ones are better than the rough texture. Maybe so. There's definitely benefits of the smooth ones, Deborah, but there are also benefits of the rough ones. So if the smooth ones were better, we'd all use the smooth ones, and we don't all use the smooth ones. And if the rough ones were better, we would all use the rough ones, and we don't all use the rough ones. Some people use a lot of smooth, some people use a lot of rough, some people use a bit of in between. So unfortunately, there's no right or wrong. But yes, if you feel like the smooth ones are better, then that's fine, because there are definitely certain benefits with the smooth ones. So yeah, fat takes like a graft. Thank you, Deborah Charlotte 007. Hope that's been helpful. Good luck with that in a year's time. Very good luck. And I hope that goes well. Here we go. Back on to the implants. Is this implant what is the grammar here, guys? Is this implant our lifetime warranty? Honestly, goodness me. Right, I'll translate. Do the implants have a lifetime warranty? I think that's broadly what we can say that's saying. So yes, you've got to be a bit careful with the warranties, because the warranties can vary as to what they cover. So I'll say all. I just said we can use any implant, but basically any implant, most of the implants we use at the clinic have got a lifetime warranty. And that sounds good, doesn't it? A lifetime warranty. You might say, oh, that's fine, I'm sorted, I've got a lifetime warranty, I'm happy. But you've got to be a bit careful in terms of interpreting what the lifetime warranty covers. So there are different sort of levels of warranty. I do like Polytex. I do think they have got a good warranty. So in terms of the lifetime warranty, what they are pretty well all covered for is lifetime warranty for rupture. So if the implant fails, if the implant ruptures for whatever reason, then you are covered in terms of the fact that they will give you another implant. So the implant's covered. So they'll give you another implant, but that's great, isn't it? Thanks very much for giving me the implant. How do I get it in there? So, the implant's only one part of the whole surgical costs. So you'd have to pay the hospital fees. So that you still have to pay quite a lot if you're just getting a new implant. The other thing is, they don't all cover capsular contracture, which is more common than rupture. So they don't all cover capsular contracture, but some of them cover some money towards the hospital costs. And the one that Polytech do, it covers you for 2 years, and they give you money towards hospital costs for any problems, as well as a lifetime warranty for rupture. But they have a 2-year warranty where they cover you for other problems like seroma infection, whatever, any problems. But after, and most are covered for between 6 and 12 months for the hospital. So most surgeries covered between 6 and 12 months in terms of revisions if things don't look right, or if you've got a dog ear, or if one's too high, or they're both too high, or one's too low, or they're both too low, or whatever. So you get covered for those sorts of problems with the hospital for 6 to 12 months. Say the Polytech ones cover you for 2 years. But after that period, if you have any problems, you will have to pay for the surgery. You might get a set of implants if it's rupture and it's under the warranty. You have to send the implant back and have to analyze it. And then depending on the company, some of them do give some money if the implant, when they send it back, is shown to be have been faulty. They will give you some money towards the hospital costs. But it's not quite as sort of comprehensive as it might sound if you say, oh, my implant's got a lifetime warranty, meaning anytime in my life, if I need my implants changed, I'm going to have them changed free of charge. That's not the case. So you have to be a bit careful in terms of what is covered in that warranty. And so that is actually a good, not the others haven't been, but that is a good question. And that leads me on to this question, which I think, because it's double question mark at the end, I think it might be the same person. Do I have to change the implant after some period of time? Simple answer, I guess, that is no. You don't have to change your implants after any period of time. A lot of people say they've got to be changed every 10 years. They haven't got to be changed every 10 years. You haven't got to change your implants at all, ever. If you haven't got any problems with them, you don't have to change them. Leave them, don't worry about them. Some people will routinely scan their patients at 10 years. I don't. But I do offer follow-up. I offer follow-up to all my patients every year. If they don't want to come, or if they're busy or whatever, that's fine. You can always just come whenever. So there's always sort of an open appointment to patients. So the reason you might want to have implants changed, you would only really change the implant if there's a problem with them. And the problem would be, as I say, the most common is probably capsular contracture, rupture, ALCL, very rare cancer associated with implants. So those are the sorts, and all of those things are basically problems. So they're usually essentially lumps, swellings, changing in shape of your breast. So if you haven't got a lump, a swelling, a changing in shape of your breast, then you know, or it hasn't got hard, then you haven't got a problematic capsule, you haven't got a problematic rupture, and you haven't got a ALCL, because those things all present as lumps or swellings with your breast. So most reasons for changing your breast are initiated by the patient. So if you don't feel there's any problems, you don't need to have your implants changed, basically. So you can keep them, as I say, they've all got a lifetime warranty. They're built to last forever. The most common problem is probably capsular contracture, which is the scar tissue forming around it. And that's scar tissue that's the problem, not the implant. It's the scar tissue that forms around the implant. So the implant's fine, often. So yeah, you don't have to have them changed. But if you get a lump, a swelling, pain, or anything like that, then hardening, then come and see us and we can talk to you about it. But don't worry, we're not going to force you to have them changed. Can you remove my breast and do breast augmentation? Now this is the question here. That was what I was trying to copy and paste at the beginning. So I'm interested in breast augmentation, and also I want to ask you if it is possible to remove my breast first and then do the breast augmentation. I want this option because my mum had breast cancer and her mum has breast cancer, and because I have very small breasts, and at the same time I'm scared of family history of breast cancer, I'd like to remove my breast first and then do the breast augmentation. So basically, I completely understand what is being suggested here, but basically so the short answer is no, I wouldn't do that, because what you're suggesting there is to do a mastectomy, so to remove the breast and then do a breast reconstruction with an implant. So breast reconstruction with an implant is completely different to a breast augmentation. No matter how small your breast is, having a cosmetic augmentation with a small breast will look completely different to a breast reconstruction. So I wouldn't do a mastectomy anyway. A breast surgeon would do that. And if you were going to have what's called a prophylactic or a risk-reducing mastectomy, which means removing a healthy breast with no evidence of any disease in it, we're just doing it because we think you've got a high risk of cancer, that would have to be done through an MDT, a multidisciplinary team. So you'd have to have a geneticist, you'd have to have a counselor, you'd have to have people who will be advising you what your risk of breast cancer is, so you can make a decision as to whether you're going to take that, take the risk of having a mastectomy over the risk of breast cancer, weigh up that risk. So it wouldn't be just like, oh, my mum and my mother and my mother's mother have had breast cancer, I want to have a mastectomy because I'm worried about cancer. You would need to be properly counselled about the consequences of having a mastectomy versus the consequences of leaving your breast and the risk of leaving your breast. So that would have to be done with a multidisciplinary team, number one. And number two, you would, from a cosmetic point of view, from the way it looks, there is quite a big difference when you just put an implant, when you take away a breast and put an implant in, because you've got an implant and then skin, basically. So when you do a mastectomy and do a breast reconstruction with an implant, you've got an implant and skin. So it is the shape, it doesn't move, the feel, the whole thing is completely different to a natural breast, and it's a different ballpark from having leaving the breast there, no matter how small it is, and then putting an implant underneath the breast. So you've got your breast sort of padding, if you like, or your breast on top of that implant. So it's a completely different thing to have a breast augmentation, which I would do. So I'd leave your breast where it is and put an implant behind it, versus taking that breast away because you're worried about cancer and then putting an implant in, because that is then a mastectomy and a reconstruction, which is a different thing. So I completely understand where you're coming from, but it wouldn't be simply a case of the surgeon saying, oh, right, you've got a small breast and you've got a family history of breast cancer. Yeah, why don't I just remove that breast and then I'll put the implant in and you'll have a similar result. It's a completely different thing, and you need to go through a completely different pathway, which probably would be best or organised by your GP. You could go down a private route for it, but that could be something you could discuss with your GP to see whether they would refer you to the breast clinic for consideration of that, so they could ascertain your risk with geneticists and counsellors and breast surgeons, etc. So, so the short answer to the question is no, I wouldn't remove your breast and do a breast augmentation. The long answer is what I said a minute ago. What's going on here, Charlotte? Hey, nice to see you again. Caught you whilst in McDonald's car park. Caught me in McDonald's car park. Where was that, Charlotte? Was that up at Cannock? Was that in my bike gear? God. McDonald's car park. Right, okay. Did I say hello? That's embarrassing. Live on TV. Charlotte, that would be my son who has forced me to do that. That would not be something I would electively do under my own steam, okay? Just make that clear. I don't sanction McDonald's. It is my child. Oh, you're in McDonald's car park. Oh. Sorry, I thought you caught me in McDonald's. Oh, God. Right, I got it. Right. You're in McDonald's car park. Right, I thought, good. Oh, God, that was embarrassing. I've just admitted to being in McDonald's car park now. Right, let's do this. Right, calm. Gloss over it. We'll delete that bit. Can you explain why most surgeons like to wait 6 months before operating? Is it a general aesthetic thing? No, it's not a general aesthetic thing, Charlotte. When you have a big burn, or if you're very ill, sometimes with people with big burns, they will go to theatre every day. The dressing changes for cleaning things, and have a general anesthetic every day. So there's no sort of, it's not great. I'm not suggesting it's good to have a general anesthetic every day, but you can have a general anesthetic every day. So it's absolutely fine. So the 6 months thing is for the tissues, really. Well, for two things. First, all the tissues. So particularly if you're having an operation in the same area, the tissues need to settle, swelling, etc. But also for your body. Whatever operation it is, it's going to knock you back. And you don't want to keep on hitting it with another operation. As I say, you can have another operation, but if it's an elective operation, so presumably you're talking about an elective thing, which is a planned thing, which is not an urgent thing. So if you have a breast augmentation, for instance, today, and you develop appendicitis tomorrow, you can go to theatre and have a general anesthetic and have your appendix removed tomorrow, no problem at all. They will remove your appendix, no problem at all. But you'll still be recovering from your breast augmentation. You'll be like, oh my God, my breast, I've got my wound down here, and infections, you've got 2 areas and stuff like that. So if it has to be done, it will be done. But if it's elective, so if you have a breast augmentation today and you want to have a tummy tuck, well, you can have a tummy tuck anytime. So you have to optimize when you do that tummy tuck. So yes, I would wait 4 to 6 months, I would say, would be a reasonable time to wait, to let your body heal, to let you get mobile, to get everything moving, so you don't get DVTs by doing repeated operations, clots in your legs, and to get you back on your feet, get the wound completely healed, everything soft and settled, so that's all sorted. So you don't have to worry about that before having the second operation. So it's really for your body, for the way your body heals the swelling, and an operation does sort of knock you back. So it's yeah, that's why I say it's one thing. So oh God. I mean, I only go with my son, all right, to McDonald's, and I haven't yeah. This is, oh God, live on air. It's a problem with live TV, guys. You live by the sword, you die by the sword. Anyone who does live TV will tell you this. Me and my colleagues, Lorraine, Piers Morgan, you know, we're all the same. When we do live TV, we have to accept that things, you know, we might get caught off guard, and we might say things that, you know, that incriminate the fast food that I feed my children. But, you know, and the blooper, that's it. In the bloopers, that's what we need. It'll be all right on the night. So, good. Thank you. Facebook's been doing very well tonight. Well done, Facebook. Instagram also good. Say Facebook better, but you know, anyway. Right, I am going to check out, and I suggest you do likewise, because I won't be here, so I don't know what else you do. You just scroll through all the other stuff when you got. Don't get into the videos on Facebook, because that is a recipe for hours gone by. But anyway, you do what you feel comfortable doing, and enjoy the rest of the evening. Next Tuesday, I'll be here. Can't see why not. What's happening? It's not half term or anything, is it? No. See you next Tuesday, 7 p.m. right here. No increment. Don't go stalking me in McDonald's car park or anything like that, like what Charlotte did. All right, or at least like what I thought Charlotte did, but she didn't. Right, checking out. See you, Elaine. Good night's sleep, because we've got a big day tomorrow, Elaine. We have got a big day, and you, my lady, are on the list. So, looking forward to seeing you tomorrow, Elaine, and hope the weather perks up. Checking out.